Thank you very much, Sarah. The first session today is entitled Research and Current Topics, and I'm very delighted to invite Professor Tom Treasure to present on setting up and recruiting into surgical trials, something which I think has been increasingly becoming more important and prevalent amongst all our centres, especially those taking part in many of the UK thoracic surgery collaborative research that's being introduced in the UK at the moment. Tom.
Thank you very much indeed, Eric, and thanks to the organisers, Johnson & Johnson, for inviting me, and nice to see you all. Now, I haven't got any slides. I've only got 15 minutes, and this is a very big topic. As you know, there are volumes written about it. There are journals devoted to this and nothing else. And you're a very mixed lot. You're thoracic surgeons, but you will have varying degrees of seniority and varying degrees of academic interest. So trying to give a talk that would meet everybody's needs wouldn't be really possible in that time. But I'd like to start by getting a sense of who you are and what your prior attitudes are. And the first question I want to ask you is this. We'll do some shows of hands. Anybody who thinks putting a show of hands is a ridiculous exercise and does not want to engage in it, put up their hands now. So you're all in. The first question has three parts to it and examines your prior attitudes. So you'll put your hands up for one of three areas. Some people think that anything other than a randomized trial will leave practice in doubt. And you really need randomized trials on just about everything to know what you're doing. That's one end of the spectrum. The other is that actually with modern methods of computing, propensity matching, modeling and so on, we no longer have to do this difficult thing of randomizing surgical patients. We can find out all we need to know from other data sets. And there will be other people who will say, well, it would depend on the circumstances. There are types of problem for which observational data works pretty well and has served us well, and there are others for which it doesn't. So let's just see, where are we? Who has come to the view and believes that anything without an RCT is probably in doubt? Okay, there's some. You're about 30, so that's about 10%. Very big confidence limits around that. At the other end, that we've got such good stats now, methods, analytical methods, powerful computing, propensity matching, we can solve nearly everything we need to know with that. That's interesting. Now, that is interesting. And who then, and that should be quite a lot of you, say, well, it depends on exactly what the research question is and what is the nature of the problem. Who'd be in that camp? Well, that's where I am too. And as you will know if you read my writings, that although I run trials, nobody else will run trials, there's tons of people who make observational studies, so I don't have to compete in that area. I can go to another area where very little is done. But I'm absolutely with people doing high-quality observational studies, and there are many things for which it works. And there are, to just remind you of the examples, a very nice paper to read on that is by Glaziou, 2007 BMJ. I often cite it and I can send it to you. But basically, he uses the mother's kiss, which is a bit of an arcane example. But it's to do with a child who's inhaled a toy, which is sort of lodged somewhere. And if the mother blows, or up their nose is the classic one, blows in the air in the mouth, they can get it to come out the nose, or the maneuver to get a piece of meat out of your larynx, a Heimlich maneuver. So the patient is dying. There is a mechanistic cause. You do something about it, and they live. No need for an RCT. Now, there are things such as that, and I think a very good example is the Thomas splint for a fracture. Huge experience of what it was like to have a fractured femur amongst miners and ostlers and farmers and all sorts of people. And bone setters in North Wales, and Thomas and his nephew, devised this means of straightening out the leg. It relieves the pain, it reduces bleeding, the patient's more comfortable, can be moved from one place to another, and in due course they come into your clinic walking like this, as opposed to one left to heal naturally, which would come in like this. And it didn't take much for people to see this was a move onwards, long before plating bones, of course. So the French and the British Army in the First World War adopted it, and it just became the standard of care. And that I would use as an example for most doctors of when you don't need it. Now, when you get onto the problems we have in cancer, there's variety. They're not clones all of the same cancer. They have a range of aggressiveness. You see them at different points in their dissemination. As well as them having different tendencies to disseminate, you see them at different points. Those two get wrapped up in one time shot of stage, and it's actually a bit of a confusion stage, because is it that they're all forming in an orderly queue and going from there through there, through there, through there, through there? No, it isn't really quite like that. Some of them romp off to metastases very, very early on, and some haven't metastasized after 10 or 15 years. So it's a very heterogeneous behavior in the patients, and then they all get treated with multiple things. They get a bit of this and a bit of chemotherapy, a bit of something else, and radiotherapy. And out of all that, to attribute the component that is surgery and its benefit is 1 million miles from the foreign body and the larynx and from the Thomas's splint. And that is why I and other people who have bothered to pay any attention to it realize that without a randomized trial, you don't really know what you're doing. And as you know, the one which we have run, and there are others going on, and you will hear about it, is mesothelioma, which is a complete muddle of knowing which of the treatments help. And the one I'm driving at the moment is metastasectomy, lung metastasectomy for colorectal cancer. But these are both examples of heterogeneity of patients caught at different stages in their progression, following different time courses, and exposed to previous treatments before you ever saw them, and eligible for subsequent treatments. So the component that the operation of metastasectomy plays in modifying their survival is quite small. But the one thing, I can tell you if you've not thought about it, removing lung metastases has no impact on symptoms other than in rare, freakish circumstances. The patients who were referred, pretty well by definition, do not have symptoms attributable to the lung metastases. If they had rib pain or pleural effusions and so on, they'd fall outside the criteria. So they're asymptomatic. When patients with colorectal cancer come to die, it is not a respiratory death other than in extremely unusual circumstances. They're jaundiced, their liver's full of disease, it's retroperitoneal, it's all over their bodies, and the burden of cancer, or they have pelvic disease, local recurrence, fistulas, and sepsis, or both. Pretty grim. But the metastases you took out 6 months, 2 years, 5 years earlier was very, very unlikely to contribute anything to their demise or their symptoms. And yet you do it. Now, of course, because I'm running Pulmic, I want you to know that. But I'm going to ask you another question now. And try and be honest. How many of you have entered patients into a multi-center research project? Randomized multi-center research project? Most of you. What was the study? Yeah, what was the study? Pulmic, good man. So there we are. Has anybody entered any patients into any studies other than Pulmic then?
Mars 2.
Good. Then you started Mars 2, and Mars 1 was a while ago and was a bit difficult. But so other than Pulmic, it's not very many, is it? So, and I know it's hard to do, and there aren't many studies to enter your patients into. But there is room for improvement, as they say. Okay, now, I want to ask you, what in your view is the biggest obstacle to recruiting patients into studies? Or put it another way, what sort of things would make recruitment into trials possible or easier? Any suggestions? Joel, you can see something on the tip of your tongue.
It's getting the patients to say yes.
Getting the patients to say yes. Okay, so getting the patients to say yes, I mean, you're not going to do that by pulling their fingernails out, are you? That's not what you have in mind. but it is reaching a point where the patient says, yeah, I see. Maybe, maybe not. Well, what do you think? Well, okay, well, let's go with the randomization. 50-50 chance I'll get benefit or not, because as you've explained to me, Mr. Dunning, so carefully, we really don't know for sure. So getting the patients to say yes involves a process which is hard to do on the first visit, once and once only. So it would be nice if culturally, as a scientific medical community, people were able to realize doubt. Now, have we got reason to doubt our current practice? Some of it, all of it? What proportion of current surgical practice, any field you like, will be, and I think Thomas Spence may well stay for quite a long time and so on, but of the type of treatments I've said to you, say cancer treatments, say treatments open to multimodality therapies, how many of them are likely to be managed the same way 10 years' time? Just 10. It's very unlikely, because if you go back 10 years, go back 20 years, it was completely different. The imaging was different. Our ability to stage was different. Available chemotherapy was different. Not much has changed in thoracic surgery in terms of the operations in 20, 30 years, other than the introduction of VATS, but anatomically, we're doing the same job. But all the other things have changed enormously. So therefore, unless the world has frozen and come to a complete standstill and there will be no more change, it'll be different in 10 years' time and 15 and 20 years' time. Does anybody contradict me on that? It seems to be relentlessly obvious, doesn't it? And also, there were things that were done 20 and 30, 40 years ago. They say, oh, did they really do that? Now, here's an example, a personal example, which I've just suddenly thought of to tell you. How are people looked after with asthma now? It's seen as an acute response to an allergen. Cats, house mites, pollens, and various other things. It is possible to characterize what the allergen is. You might desensitize, but at least you can avoid it. The way you run your house, how you get rid of carpets and so on, and you choose to keep the cat in a shed at the bottom of the garden rather than under your bed, and so on. What is the therapy? Well, the current therapy is based around inhaled steroids and bronchodilators, short and long acting. That's the current management of asthma. What do you think it was? What was the belief about asthma when I was 10 years old? So I have to admit, we are going back more than half a century here. But because I was put in hospital for 6 months in a TB sanatorium. TB was on its way down, so they had spare beds so they could park children there, I suppose, at the age of 11 to treat my asthma, which was so bad, few nights could I get to sleep. I couldn't exercise at all. As soon as I tried running, I'd have asthma. And life was, well, you live your life. But it was actually pretty miserable. So I was put in a hospital for 6 months. Why? Not far off. But do you really know what was the belief about asthma then? It was that it was due to my mother. My mother's relationship with me created me to get stressed and deliver this stress in the form of asthma. When I was taken out of my mother's house and put in a windswept, lino-floored, no soft furnishing TB sanatorium on the top of a hill in Gloucester, I could breathe like nobody's business. Go back for a weekend with my mother, 3 months without going home at all. 1 visit a week. Put back in there, on came the asthma. Cause and effect, proof. No. Causation must not be confused with association. And that's why you sometimes have to randomize, and quite often have to randomize. So the observation that take me from there to there, and I didn't get asthma, was true, but taking me from there to there took me away from cats and house mice. So the theories, the therapy has changed dramatically and enormously and is a spectacular success story. Because at the time, the only medication was either to go to the hospital for an injection of adrenaline, which I never had, or be given Franol tablets, which you swallowed. That was ephedrine. And then I'd go around like this. I wasn't much less wheezy, but I was much more jangly. And so it went on, and then people killed themselves with inhaled and sublingual isoprenaline by overdosing, and now it's all completely different. So that's changed. Common little thing. And just about everything you care to think of has changed like that. And that's why you've got to find the way in. And I would say the biggest two obstacles, and Joel really hit upon it, coming at it from a different route, two obstacles to doing randomized trials are lack of self-doubt, certainty that we know what we are doing. That is the biggest obstacle, that you find it very, very hard to accept that the oncologist isn't sending you a patient for good reason. Well, they know what they're doing. I mean, they look after it. It's my job to do it, and this is what they expect of me. That lack of self-doubt. But in addition to self-doubt, the willingness to challenge. And there's a book I think you should all read if you haven't all got it already. Has anybody seen Sam Nashev's book, The Naked Surgeon? And you know who Sam Nashev is, the cardiac surgeon at Papworth. It is outstanding because he deals with cardiac surgery and expands it to the rest of us, coming to terms with conceit, arrogance, being fully opinionated. And as a student, he went through Bristol. And his story is not to do with the cardiac surgery, that he covers that, but to do with leaking abdominal aneurysms and who gets the best surgery. And he was told to shut up, treated like a naughty boy, because he dared to think that it was reasonable to look at the figures. And Sam, most other people would have said, well, if I want to get on this career, I better knuckle down and do what they expect of me. Sam didn't. He went to Manchester. He was the first one to implement a risk score. He sat and worked for a long time putting together the Euroscore, and it's a great book. And he covers a lot of issues to do with us really questioning what we do and being prepared to look at the actual results of our treatment and analyze it when it's not clear. And so in the case of multimodality therapy of colorectal cancer, and in particular lung metastases, it is too muddled and opaque to be able to see cause and effect. And so that's why you need to put patients into trials. So my subject was how to design the trials, how to implement them, but too big. But what you have to do is be prepared to say, we might be wrong about this one, and communicate that doubt to your patients and man up and contradict your oncologists and whoever else tells you we know what we're doing, because they don't any better than you do. There we are, 50 minutes.
Thank you very much. I think maybe we have time for one question and then we'll do a general discussion at the end. Are there any questions from the floor? And if not, can I pose one question to you, Tom? I think in my own practice, I believe that 90% of what I'm doing, I'm in doubt of the efficacy, including decortication, just everything, whether we need to stage the mediastinum, whether we should offer surgery or no surgery for early stage lung cancer. I'm in doubt of the whole process. Can I just ask you, one difficulty I find in randomizing into trials is that the people around you, as you said, don't have doubt. And that's not just the surgical team, it's the wider MDT. So in PALMIX, with oncologists not having any doubt, they think that they know what to do, or your colleagues looking at you as if, are you crazy? You know, we know what's best. How come you don't know what's best? And if you don't know what's best, then clearly you're not performing to the same standard as we do. So how would you approach those issues?
It's very good, a very good point. Now, just thinking of something Sam Nashev said, but in his book, and it'll come to mind in a minute, he touches on this. But I think that's why I say it's got to be cultural. And I am surprised that in a country which has a Department of Health and very well-established health service research and NICE and a health service, that carrying on delivering unproven treatments is wrong, and we shouldn't be doing it. You know, where it's just, you go to a surgeon, you pay him, and he takes the money and runs. You know, that's the way they do it. But we thought we did it better than that. And that's what I believe. But the other thing is this, that if we take Sam's example is a cardiac surgeon, but it applies across the board. To go into an operating theatre, to take up a knife and cut someone's chest open and put them on bypass and stop their heart and expect it to go again requires an extraordinary level of self-confidence. And when you talk to people socially about what you do, and the same would apply, of course, of anaesthetizing a patient and taking over their lungs and ventilating them, or any of the other things, and giving them 3 months' worth of chemotherapy, horrible chemotherapy, you've really got to believe in yourself that you're doing the right thing. Otherwise, life would be intolerable. And a surgeon who has self-doubt is such a pain in the operating theatre. When I was an SHO, I worked for an orthopedic surgeon who barely before he'd started, very unusual amongst orthopedic surgeons, but he said, oh dear, I wonder if we're doing the right thing here. Oh dear, I wonder if this is the right thing. And I learned from that you can have doubts, but when you're in the middle of an operation, you've got to say, come on, we need to stop that bleeding, we need to sort that out. Good, everybody's with it? Yeah, thanks. I've got some blood in the bank. You've got to be prepared to be in command. And I think that is the difficulty, having another way of thinking which you can't exhibit constantly in front of the team or in front of patients, because you've got to get through the day, and you've got to inspire confidence in your patients, in your team. And to distinguish between that need as a good doctor and as a good surgeon, it's a necessity. With private moments when you say to each other, that's about the 4th time this happened this month, Eric, are we doing the right thing here? And these conversations should be had, and what will we do about it? And it may be do a trial, or it may be just audit, or whatever it is, but doubt has to come in. Can I take them, or is it too late?
Sash, can you save it for the discussion, and then we'll carry on afterwards? Thank you very much, Tom.